Senior Registrar at Sefako Makati University. My talk will be on the management of lymph nodes in penile cancer. So my talk, the scope, sorry about that. So the scope, I have the introduction, then we look at the staging of penile CA, in particular squamous cell carcinoma, and then restratification with as it's the one that mainly guides our management of lymph node disease in penile CA, and then of course diving into the actual topic, and then we look at how we follow up this patient, and of course wrap it up with with a look into promising developments in the field of penile CA, squamous cell carcinoma. So squamous cell carcinoma is a curable disease if picked early, but it's quite deadly if picked late, especially if now patient presents with advanced metastatic or regional lymph node disease or beyond regional lymph node extension. The local treatment can be mutilating, hence sometimes actually leaving us with no option, but actually to go for the route when it comes to the management of the primary lesion. It accounts for 0.5% of all cancers in affluent societies, and in our societies can be 2%. At times, some countries can even go to 10% of the burden of disease of cancers. The annual incidence that is seen in excessive numbers is noted in countries like Uganda as well as Brazil, can account for about 8.3 per 100,000 population. The predominant histology is the squamous cell carcinoma, and the risk factors, the risk factor being the most predominant or the most common culprit being the human papilloma virus, in particular your type 16 and 18. What predicts, if you have a penile CA, what predicts the involvement of lymph nodes? It could depend on the primary tumor, the grade of the primary tumor. Is there the stage of the primary tumor? The higher the stage, the higher the risk. Is there any invasion of lymphovascular structures? Any perineural as well as molecular markers like the presence of TP53, KI's x264 positivity or squamous cell carcinoma antigen positivity of these tumors, as well as the PK16 anchor, which is seen in HPV-associated kind of penile cancer, SCC. These, if it's positive, the likelihood of an occurrence of mets into the inguinal lymph node is also on the higher side. Looking into the lymph node drainage of the penis. We can, so we have basically the foreskin and the shaft. I'm seeing a message that says my connection is not that sharp. I hope you are still seeing my slides and you can hear me.
Dr. Dlamini, it's coming through perfectly.
Okay, thank you. Sorry for that. And then in terms of the drainage, so the skin in the foreshaft will drain into your superficial inguinal nodes. And then from there, before it gets there, it is said, Cabanas and colleagues, they did their work of lymph angiographic studies to actually try and understand and appreciate the drainage of this organ, and it was noted that at the symphyseal area there could be crossover in terms of some drainage going to the left or into the right of the inguinal lymph nodes, but there is no drainage that goes directly into the pelvic basin. And also when from the superficial inguinal basin, it then drains into the deep side. So superficially, if it's above the fasciolata, and the deep ones, they are below the fasciolata, and they are mostly, the deep ones, they are mostly medial to the femoral vessels. And the superficial ones, you have actually about 5 zones according to Dassela. The zone 1 being the central one at the fossa ovalis, where the great saphenous vein enters into the femoral vein. And then you have on the superior lateral side, you have zone 2, then 3, superior inferior, inferior lateral, and then superior medial being your zone 4 and inferior inferior medial being your zone 5 around the saphena magna. And when you do a superficial inguinal lymph nodes, basically you'll be taking these 5 zones in the superficial. And then when you're going radical lymph node dissection of the inguinal lymph nodes, you'll be actually taking all the 5 here and also down opening the fascia lata and taking the lymph nodes medial to the big vessels. And the superior, the most cephalad of the superior lymph node is known as the lymph node of Cloet, and that's our cephalad, the most cephalad dissection that we do when we do the radical lymph node. And when you do pelvic lymph nodes, when you're coming down, it will be your most inferior node to marker to say you've done adequately in your pelvic lymph node dissection. If you're doing a modified inguinal lymph node dissection, you will be taking the superficial on the medial side, and we will see the borders as we go along. And quickly, the staging according to the 8th edition of the American Joint Cancer Committee, in particular the lymph node staging. Clinically, based on your examination, it can be a CNX 0 if lymph nodes cannot be assessed. If it cannot be assessed, and CN 0 if they are not palpable. CN 1 if you have one palpable lymph node and it's mobile. If you have 2, whether unilaterally or bilaterally, and they are mobile, it's CN2. And then if you have a fixed not mobile, not mobile, and of larger size, you say to be having a CN3. And then post your dissection, your lymph node dissection, you send for histology, you get a report. You can also give a pathological nodal staging of the tumor, where PNX and PN0 it's as known, and then pathological N1 is when you find that there are at least 2 or less unilateral inguinal lymph nodes, and there is no extranodal extension on these nodes. And PN2 if there are 3 or more unilateral inguinal nodes, or they can be bilateral. If the patient is PN3, it means there were positive pelvic node, or there was extranodal extension of the node. In terms of diagnosing lymph node involvement, so there's clinical examination, as I alluded to already, and then you can do imaging. But in terms of imaging modalities, the sensitivity and specificity is poor of these modalities: ultrasound, MRI, CT, or FDG PET, CT, if the patient is clinically lymph node negative. But in clinically lymph node positive cases, now these the modalities are actually helpful in as far as staging disease. And actually EAU provides a strong recommendation in terms of doing CT or PET CT imaging in patients with intermediate risk or high risk of squamous cell carcinoma if their nodes are positive. And then you can do also, they can, historically, we would do a fine needle aspiration, then send for cytology. And you can also do advanced modalities like dynamic sentinel lymph node biopsy, or you can do your modified inguinal lymph node dissection, as I already explained it before. And it can either be open or laparoscopic, or you can just take the superficial lymph nodes by doing a superficial inguinal lymph node dissection. In terms of the management, penile cancer, first you deal with the primary lesion, you send for histological analysis, and then you get your report. And then that report will help you now to combine your information so that you can now deal with the lymph node disease. So lymph node management then follows thereof, and it is actually, the lymph node disease is the major prognostic factor for survival in these patients. Lymphadenectomy alone can be curative of this cancer. In those patients presenting with advanced disease, then you have to do systemic disease management. And then with all your management, your patients have to be on follow-up. And penile cancer is one cancer that needs astute follow-up parameters, especially if you have opted for measures like organ preservation techniques, because recurrences, it is renowned for recurrences. So diving into the management of the lymph nodes. So as I said, depending on the primary tumor histology, the staging, the clinical status on your exam, is it palpable or not palpable? And then you restratify combining these above factors. If it was not palpable yet is intermediate risk, you have to do diagnostics in terms of a dynamic sentinel or modified inguinal lymph node dissection. And then, of course, positive, and then you have to do the dissection, whether you do a modified or you do the radical inguinal lymph node plus or with or without pelvic lymph node dissection. So if when you do your when you do your radical inguinal lymph node, you find that the patient has got 2 or more positive nodes. The frozen section is positive also on your deep dissection. You then opt for ipsilateral pelvic lymph node dissection. This you can do in same setting, or you can do it subsequently. This you can do openly as well, or you can do it as laparoscopically, and the template can be the same. If you are doing radical inguinal lymph node dissection, I think I already explained this. The only thing that I have to allude to in this diagram from Campbell-Walsh is the boundaries of your modified, the boundaries of your radical. You use a femoral triangle on your radical, with the base being your inguinal ligament, and then the adductor longus forming the medial margin, and its lateral edge, and the medial edge of the sartorius, it forms your lateral border, and then the apex being at the where there's two muscles meet. In terms of the extent of the dissection, you're going superficially and also below the fascia on the radical, and you're taking, as I said, you go for the central superior, and then superior lateral inferior, and then you have basically an incision underneath from the aces into the pubic tubercle, and then you have one running longitudinally of about 15 centimeters laterally, and then medially it will be about 10 centimeters, and then a line joining the two in your radical dissection. So you also have to sacrifice for this the great saphenous vein here, and also you have to do a sartorius flap. So it is quite a morbid issues. In your modified, you also use a modified femoral triangle, kind of a femoral triangle, because instead of using the sartorius, now you use the femoral artery, and your dissection stays medial to the femoral artery. In terms of now restratification of your inguinal lymph node, you, according to the NCCN 2018, can be a low risk. That is, the patient is on your pathological staging. It's got a TIS or a TA or a PT1 grade 1 lesion. So those patients will be low risk. The intermediate risk one is if the patient has got a pathological T1 with the grade 2 on the lesion on histology. And then the highest risk ones, the high risk ones, they are T1B, which is PT1 G3, G4, or up to T4 disease, and or it's any T with lymphovascular invasion. So they carry a high risk to progression into lymph node metastasis. This patient, these ones is an intermediate risk. And then the other risk status is bulky disease. And then how we manage your low risk. So it depends, is the patient having a palpable disease or non-palpable disease on clinical examination. If it's non-palpable and this patient is low risk, you just, then after management of your primary tumor, you then follow up the patient. If it is palpable, then the likelihood of malignancy is high. So you have to go for an ipsilateral radical inguinal lymph node dissection, as I explained which parameters will guide you. Try to go for superficial inguinal lymph node dissection with frozen section, and if it's negative, you just survey the patient. If it's positive, you will then proceed accordingly, like you did on the ipsilateral palpable side. If your patient is intermediate risk, again, you look, is the disease, are the lymph nodes palpable, or non-palpable, or are they palpable? If they are non-palpable, you take the non-palpable arm. You ask yourself, is the patient before me a compliant kind of a patient? That is, will this patient actually comply to a surveillance schedule? If yes, then you can actually carefully select those patients for surveillance. And then if your patient, you're seeing that you're struggling with compliance, you probably have to do diagnostics on the inguinal lymph nodes. That's where you now go for bilateral modified inguinal lymph node dissection, or a dynamic sentinel lymph node by dissection if you have the capacity as a facility, or also you do a video endoscopic inguinal lymph node dissection. So if it's positive, you then manage like in a palpable positive inguinal lymph node, where you do a radical dissection. And then if it's negative, you surveil the patient. Otherwise, the one who presents with palpable disease, you go for an ipsilateral radical inguinal lymph node dissection, and then contralaterally, the side that is not palpable, it's not positive, you do superficial with frozen section and proceed accordingly. Otherwise, the high-risk patients, you're not taking chances, palpable or not palpable. If comes to you, they are not palpable bilaterally, you're still going to go in and do a superficial inguinal lymph node as one of your options, or you do a modified inguinal lymph node dissection as your other option, or dynamic sentinel lymph node biopsy, or a video endoscopic inguinal lymph node. If it's negative, you survey the patient. If it's positive, you do a radical dissection with plus or minus pelvic lymph node dissection. And then depending if the pathology says PN2 or PN3, or that is pathological N2 stage, N3, or also if there's extra capsular nodal extension on the nodes that you picked, you have to offer, you can also offer adjuvant chemotherapy. If one side is palpable, the other is not palpable, on the palpable side, you go for a radical treatment. The contralateral side, you go for superficial inguinal lymph node dissection with frozen section, and you proceed accordingly. Bilateral palpable candidates, those ones are troublesome. You have to go for bilateral radical treatment, plus or minus pelvic lymph node dissection bilateral, and also with adjuvant chemotherapy thereafter. These recertification management strategies are also emphasized by the EUA 21. This is the summary, basically the summary of what we just went through. Comparison of Shao and colleagues in 2022 recently released paper. They did a comparison of different surgical methods and strategies for inguinal lymph node dissection in patients with penile cancer. They actually looked at about 40 of the patients were given laparoscopic inguinal lymph node dissection, and about 69 were actually given an open. The template was pretty much the same, and in particular, their interest was looking at what are the survival outcomes in those patients that are operated late, and what are what were the yields on the inguinal lymph nodes, and also what was the overall survival in terms of their follow-up of these patients, and also the progression-free survival. So when you look at this Kaplan chart, you can see that actually the outcomes are actually comparable between the two modalities. And even in terms of those patients that were done early or delayed, though the teaching has been that if you delay, actually you run the risk of finding actually extensive disease such that you will lose your opportunity in terms of cure. Then the delayed cases, they were just basically following them closely every 3 months clinically and with imaging. And the trigger to go for a dissection would be an increase in size of the lymph nodes. And then the only difference that they noted in this study was that the rate procedure is higher as compared to the minimally invasive approach. Treatment of the bulky disease, that is, you find that the tumor at the lymph node is more than 4 centimeters is fixed, or they are already positive lymph nodes on the or patient on presentation is called de novo pelvic lymph disease. So there you have to give the patient inductive chemo, and then you assess for any response. If there is positive response and the disease that is stabilizes, then you go for your lymph node treatment in terms of surgery. And then if there is poor, the disease progresses despite your inductive chemo, and then probably a patient can be recruited for clinical trial or go for palliative chemoradiation therapy and follow up as a hospice case. Indications for pelvic lymph node dissection, I think I already alluded to that. No, worth mentioning is that your 5-year survival, if you have positive pelvic lymph nodes, is very, very, very affected now, because it's at 33% versus those guys who do not have it, which is actually at 71%. Now, how about the patient that you've treated, and then on follow-up, you see that actually there's disease that is coming back. How you manage will depend on the initial status of the inguinal lymph nodes. In terms of what on clinically, when the patient presented with a primary tumor, what was the situation on the inguinals, and then what treatment modality initially did you do for the inguinal disease, if there was any. If there wasn't and your patient was on surveillance, then you will actually then assess and stage the clinical, the nodal disease, and then manage according to the staging. But otherwise, if you had done something in terms of, i.e., you had previously did a lymph node dissection radically or a modified or a superficial, managing this patient is quite tricky now because the drainage has been tampered with. It's difficult to ascertain the extent of disease, even to pick on clinical exam or imaging. So these patients, we tend to put them on multimodal therapy, chemo or salvage surgery, but they are generally a difficult kettle of fish, these patients. Complication of this lymph node dissection, you have to deal with a lot of lymphedema issues, lymphocytes, wound sepsis or dehiscence, in particular your radical dissections, flap necrosis, as well as thromboembolic disorders. The Journal of Urology, the Indian Journal of Urology, I think these guys, they compared outcomes of robotic and open inguinal lymph node dissection in patients with penile squamous cell carcinoma. Generally, the yield of lymph node was actually comparable between the two arms. The only difference they noted, which was also basically in keeping with what the guys in China saw, was the issue of the rate of your morbid side effect or complications with your open dissection. In terms of following up these patients, the EAU, of course, on your primary tumor will guide you as to whether did you do an amputation or you did an organ preservation. But otherwise, in our topic of the day being the inguinal lymph nodes, if the patient was on surveillance, you follow them up every 3 months, and then in the first every 3 months, and then every 6 months for 5 years. So 3 months in the first 2 years and 6 months the last 3 years. The recommendation is strong. And then also that depends if was the patient pathologically N0 at initial treatment, 3 months, and then thereafter. So you do your physical examination, your ultrasound. If need be, you can do a fine needle aspiration or even imaging if they are positive. So now, in terms of the future, is there a role of neoadjuvant treatment in clinical nodal positive patients, or offering prophylactic pelvic lymph node dissection upfront in this patient? According to the IMPACT trial, which is actually currently recruiting, we yet to know, because we want to know if actually if you are with our nodal positive patients, should we continue with what we are doing, or are we going to have a difference if upfront we offer this patient neoadjuvant chemo and then we go back and do the surgery, the lymph node dissection, or they are also putting the other patients on chemo radiation as a neoadjuvant measure, and then you go on and operate. So we are waiting the outcomes. Last slide. These guys, they look at the fate of the patient with bulky nodal disease, so basically metastatic ones. So these patients are noted to be having poor outcomes. About 40 to 60% of these patients, they tend to have a tumor that is now PD, a programmed death ligand 1 positive, and most are usually systemic refractory. So hence now the pembrolizumab phase 2 trial to try and appreciate if this patient can be helped, like we see in patients in cancers that are immunogenic in urology, like your melanoma of the penis or your RCC. So taking from this paper, these guys actually did a case series of 3 patients. Of the 3 patients, actually 2 patients progressed despite pembrolizumab, but at least one had a good response, so much that they were able to offer this patient salvage surgery. And as we speak, is at 38 months of follow-up, this patient is actually doing well. So there's still a lot of work that is being done on the use of immuno-oncology to see if it can also be added into the armamentarium for the management of penile cell carcinoma. Thank you. This was my last slide.
Dr. Dlamini, congratulations. A very comprehensive and clear talk. I see we've got one person who has asked a question there. Perhaps you can direct your answer to Dr. Jeremy. He said for HIV patients with low-risk penile cancer in which they have already bilateral palpable inguinal lymph nodes, is there any specific recommendation for these patients since negative rates of nodes are high? So I think he's making the point that HIV patients have many reasons to have palpable nodes. Any specific recommendations you've read about?
Honestly, I didn't come across anything on that, but in terms of, I'm aware of the fact that the HIV does not increase the risk of squamous cell carcinoma of the penis. But yes, in patients with the human papillomavirus, the aggressivity of human papillomavirus is actually enhanced by HIV. But in terms of now, if you have HIV, I mean, you can have positive lymph nodes. As far as in a patient with a penile lesion that has been diagnosed as penile cancer, if the lymph nodes are positive, you treat them as metastasis until proven otherwise, that is until you have histology.
I think that's a very sensible oncological principle, that you can't simply ignore them and you manage them in the same way. I thought that penile cancer did have a high incidence in HIV. I need to go and check that. Certainly there's a nice work coming from our colleagues at University of Free State who have shown a higher HPV positivity in the HIV patients who have penile cancer. Just wondering if there are any questions for Dr. Dlamini. Please just put your hand up and we'd love to hear from you to get some discussion going on this core topic. I'm sure there are some issues that could help be clarified. Dr. Dlamini, from my side, I think that one of the challenges for someone approaching this topic for the first time is to understand the different surgeries that are possible. You mentioned radical, you mentioned modified inguinal lymph node dissection, you mentioned superficial lymph node dissection, you mentioned dynamic sentinel lymph node biopsy. You mentioned even, and I take it, robotic lymph node dissection. You said the video endoscopic version, I presume that's a robotic option. So lots of different things, but I think clarifying particularly what the difference is between modified and superficial would help people to understand what the difference is and where you would apply those different operations.
So, Prof, on your superficial inguinal lymph node dissection, basically you are basically that your template is basically the lymph nodes above the tensor, fascia lata. So as I alluded to the Dasella zones, you are taking your central zone, your superior lateral, inferior lateral, medial, superior medial, and inferior medial above the fascia. But so you can say that actually you go even lateral to the big vessels in that case. But when it comes to your modified, and also you are guided by the femoral triangle. So your sartorius muscle and adductor longus and your inguinal ligament. But on modified, you are guided medially by the adductor longus, but laterally it's no longer now the sartorius. You use the femoral artery, and then your dissection stays medial into the femoral artery, and you are taking the cephalad extent is your fossa ovalis, and then going up on the medial side of that.
I think that's a nice anatomical description, and that's a good place to start. I just think, in my thinking, the word modified confuses people. And as I have it, modified is really simply an alternative to a radical lymph node dissection. We know that there's a huge amount of morbidity for our patients with a proper radical lymph node dissection. So the modified is simply a radical in an attempt to reduce the morbidity. So the template is smaller. You attempt to preserve the sapness. And so by doing so, you're simply achieving the same oncological as a radical, but with a few additional features which can reduce the morbidity. So it's not to be confused with superficial, which is, to my mind, more of a diagnostic procedure. in the setting of impalpable nodes. I suppose the cases we come across commonly do have palpable nodes, so it's really the debate about impalpable nodes is unfortunately somewhat a debate that we don't often encounter, because most of our patients require a radical lymph node dissection. We have had some experience with dynamic sentinel lymph node biopsies some years ago in the very few patients who we have cause to do that, and it isn't actually a particularly difficult procedure. The people are doing it at most hospitals regularly for breast, and so they simply can bring along their kit and apply the same principles using the gamma camera and the patent blue to define the landing zone node. And I think it's worthwhile to try and develop it a little bit further at our and other institutions so that we have these skills available. I'm just looking around to see if there are any other questions. Don't see anyone else ask. I think Dr. Linguiski has suggested a nice solution there for the HIV option, is to do something more modest, and I suppose that one has to be a little bit cautious about just simply doing a dynamic sentinel lymph node. If you in fact do have palpable nodes, I think you've probably got to follow what Dr. Dlamini said and play it safe and do at least a superficial lymph node dissection for those patients, I would have thought. The other thing is, I think, not to avoid unnecessary surgery or to give you confidence to do a radical. We've used cytology quite nicely, and the books certainly say that the addition of ultrasound there to see the features of positive nodes combined with cytology, fine needle cytology, can be quite helpful preoperatively to help you plan. I'm surprised. I was expecting a few more questions because this is such a core topic. Just seeing if any last people would like to ask some questions, but if not, Dr. Dlamini, thank you very much for an excellent talk this morning.
Thank you, Prof.
We're going to move to our colleague from Cape Town, who's recently joined us from Cape, Dr. Masithemba Mandla, and he's going to be talking to us about prior prism. So, Masi, if you want